Hello, and welcome back to another episode of More Than Milestones. I am incredibly excited and honored to be joined by this group of women here today to really break down the huge conversation around tethered oral tissues and all of the things. So this is going to be a little bit of a different style podcast than we've done before. This is a little bit more of a round table because there's 4 of us total. In this episode, I will be more of Mom Casey as the one who's navigated this with 2 kids now, one I chose to release, one I chose not to, and I'm kind of in that process right now of what's next. So I'm going to turn it over so everyone can introduce themselves, and then we will get right into it. But I hope this is a very impactful and informative episode for anyone that is navigating this or might be navigating it in the future. So, Bri, I'll start with you. Go ahead.
Cool. Sounds good. So I'm Brianna. Casey, thank you for having me back on another episode. I'm really excited to be here. So I am a speech language pathologist by trade, and my clinical focus is on infants and medically complex children. I also just got my PhD, so very excited about that. And my research focus is on misinformation in pediatric feeding on social media. And actually, my dissertation title is Analysis of Misinformation About Tongue Ties on Instagram. So very relevant to today's topic. I'm a mom to a 15-month-old, so kind of navigating that new mom motherhood side of stuff. And then outside of that, I own a business called Pediatric Feeding Therapy where I do continuing education. I also have a podcast called The Feeding Pod. And I do some consultations and all that side of stuff in addition to it. So happy to be here.
Sure. Hi, I'm Larson. I'm also a speech language pathologist at Boston Children's Hospital, where I'm the director of the feeding and swallowing program. And I've been here a really long time, going on 28 years. And so I work in the airway clinic and the aerodigestive center here and do clinical research on aerodigestive disorders, see lots of newborns and little babies that have question of, is this a tongue tie? Yes, no, what do we do about it? And then I teach the craniofacial course at Boston University. And thank you so much for inviting me. I'm really, really happy to be here.
Absolutely. I'm so honestly, I have been looking forward to this since we first scheduled. I'm so excited. And Yvonne, go ahead.
Yeah, so I'm Yvonne LeFort, and I live in Auckland in New Zealand, and I'm a family practitioner, and I've been working with the area of breastfeeding support and breastfeeding medicine for over 20 years. And my initial introduction to the whole area of tongue tie was through Dr. Evelyn Jan, who was the family doctor in Canada who set up the first breastfeeding clinic. And she did some of the very earliest education on tongue ties and breastfeeding. So my experience has always been, unlike speech language therapists, it's always been in the breastfeeding realm. So I've worked in that area for quite a while, and I've also been quite involved with the Academy of Breastfeeding Medicine and was very instrumental in getting our position statement on ankyloglossia and breastfeeding infants, dyads really, into publication. And I'm currently involved with the team that's rewriting the clinical protocol on ankyloglossia for the Academy of Breastfeeding Medicine.
I thought that kind of a nice spot to start would be just an overview for the lay person. What is the overview of tethered oral tissues?
Well, I might just start because I think the original research is very much tied in with breastfeeding. The original awareness of this issue goes back, hundreds of years. But when you look at around the year 2000, 1999, there was original really good randomized controlled trials that showed us that the tongue was intricately involved in successful breastfeeding, pain-free breastfeeding, and actual effective breastfeeding, transferring the milk from the mother's breast to the infant. So that's where it all started. And really the best evidence for what we do is really still in those early parts of the 2000s.
Yeah, I think taking it a step further too is that if we think about so what is a tongue tie, right? Or what's called a tethered oral tissue. And that really means that the frenulum, which is under the tongue, and everybody has a frenulum under the tongue. If you lift your tongue, you're going to see it looks like a little line crease that happens. It's where the fascia comes together. And when it becomes a tie is when it is so tight that it is restricting functional movement. And what we've seen in the research, like Yvonne just mentioned early on, and what we see repeatedly is that breastfeeding is really kind of the only area we're seeing consistently this may, and I want to be may impact what is going on. And then, on the side of the lip tie, or people talk about buccal ties or cheek ties, the same concept of like, oh, this is a tissue that is so restrictive, it's impacting movement. But really what we see pretty consistently is that a lip tie and or buccal ties really do not have any functional implications from the feeding standpoint, from a speech standpoint, a sleep standpoint. I mean, lots and lots of things that you'll see on social media and that many professionals claim, but we really don't see that. And there's one article specifically it was like Santa Marina and colleagues in 2017, where they looked at the actual like anatomy of labial frenulums in newborns. And what they found was that actually the majority of newborns had what most people call the most severe level of a lip tie. Most newborns are born with it all the way down to the bottom of the ridge, and that's what it looks like. And previously it was thought, well, that's going to impact latch because they cannot flange their lips. And what we know now is that we don't need the lips fully flanged outward. We really just need a neutral, comfortable position during a latch. And so that's kind of like another reason why looking at the research side of stuff is so important, because it's really easy to pathologize something that's actually a very, very normal part of development. So I think that's just a good example of the lip tie one. The buccal tie one gets me going in a whole different way, because I was just way out there. I know Cara has a case that she saw the little one with the cheek support. You can tell that story if you want.
I think I would add just that it's also like function over form, right? That we are all born with this fascia, right? Like we all have a lingual frenulum. We all have a labial frenulum. We have buccal frenula, and they serve a purpose for when you're eating, to keep the food together, to push it from the front to the back of the mouth. So there is function there. And I think that you can't look at a tongue tie, right? We always say like really tight tongues operate beautifully, and what looks like a tongue that has great range of motion might show some restriction or difficulty with breastfeeding or milk transfer. For function over form, for sure.
Oh, I'm already sweating a little bit. I feel like here, Mom Casey is a little. I gotta turn the fan on. Okay, so the reason I say that is because I feel like we, as parents, we need to hear that, because when you are being told something by someone in a position of authority, even well-meaning, it can be really easy if visually you are seeing what they're saying, right? Like I'm looking at my daughter's tongue as you're describing to me, and I'm like, oh my God, that is problematic. Like, let's do it, until you like take the emotion out of it and actually think about functionally, is anything really going on right now that needs to be addressed? And so as much as it's making me sweat a little bit, I feel like this is exactly what parents need, is that unbiased information of how to look at this through the lens of what is real and what is not, and what the gray area is. So leading into that, there are obviously a lot of professionals related to managing or having clinical expertise in tethered oral tissue. Can you break down for us kind of who those professionals might be and what their role, the most popular ones, what their role might be for parents who are even just trying to figure out who to start with, who to go to for an initial assessment?
If it's a breastfeeding dyad, then their first port of call is somebody who is knowledgeable and skilled in breastfeeding management. And that includes lactation consultants, but also people who practice breastfeeding medicine, who are either DOs or MDs, or particularly medical doctors, pediatricians or family doctors, what have you, surgeons. And I think that they are probably most capable in discerning. And I think that's a word that doesn't appear on social media about tongue tie and tethered tissues, is discerning. So not, as we said, it's not an anatomical diagnosis. So there's a whole area of skill that has to be tapped into before a procedure is done, or before the decision is made to do a procedure or not do a procedure. And the decision rests with the family, the practitioner, who could be, in my country, a midwife, an oral surgeon, dentist, a doctor. So all of these people are trained in the procedure. But to me, the procedure is one thing, but it's this whole giant area of assessment and informed consent is where the skill lies. But if it's breastfeeding, please, make sure the person that you're approaching is breastfeeding knowledgeable and skilled.
I think that's really important. Many of us as speech language pathologists, myself and Bree, are CLC, certified lactation consultants. So we've got the breastfeeding feeding piece of it, along with the understanding of the anatomy and physiology of the oral cavity and pharyngeal swallow. And so if you're working with a speech language pathologist, you want to make sure that they have an understanding of breastfeeding. In my hospital, we work closely with ear, nose, throat. So otolaryngologists or an ENT, pediatric ENT. And we have set up an algorithm, which is just basically a pathway where it says, if someone's coming in with a tongue tie, they're going to see the SLP, who specializes in infant feeding and swallowing, and ENT on the same day, one right after the other, so that the SLP can assess breast and bottle feeding, and if indicated, see ENT for further evaluation, and if indicated, a scissors release in the office. And that has been super helpful in educating families, and many times not even getting to the ENT visit because there is no tongue tie. And one important thing I want to say is if you can go to a hospital, parents can utilize insurance versus going to a dentist where it is cash and private pay and your infant is not yet on your dental insurance. So if someone is in an area where they can access a pediatric hospital or pediatric ENT, and you're using your health insurance and you're not paying out of pocket, which can be hundreds and hundreds of dollars for 1 or 2 or 3 releases.
Wow. That, like, did everyone hear that? I feel like that's very important information. But now, does that also apply to older children, or is that solely in that?
That's older children as
Great.
well.
Good to know.
I think too, like, it's important to note, if you go somewhere and you're feeling like pressured financially at all, there are other options available, and that should be a red flag. Like, I know some providers in the area where it's cash pay and they say, but if you do it today, we'll give you a discount. So they're immediately taking away your ability to go think about it a little bit longer to seek out another opinion. Or they do things like, but don't worry, we have like a medical credit card you can put it on and then pay off. And like, those are major red flags when you have the option to go see an otolaryngologist, or even in some places, the pediatrician will do the procedure depending on the infant's age, completely covered. Because if it is truly medically necessary, this procedure will be covered by your insurance.
There's an interesting little piece of data emerging from the United States about when they look at equity and the procedure being available. It's that way more people with private insurance are being treated than people that have the government sort of basic level of medical insurance. And in countries like ours, we see non-equity because the procedure is not uniformly funded within our public health system. So for instance, for me, I'm a private practitioner and people need to pay to see me. I need to pay my expenses and what have you. And nobody gets rich from breastfeeding medicine, but it's an equity issue there that's quite significant, even outside of your structure with insurance in the United States. Quite across the world, there's equity issues.
Yeah.
I think that incentive goes back a little bit too to what you said, Cara, about like how going through a very like a formula process for the providers to see. And Yvonne, you mentioned this too. Like, it's really important to make sure that the providers we're seeing don't just have the credentials to say they should have an expertise in this area, but they also have that additional training. So going to see the lactation specific provider if breastfeeding is what the issue is. And I think in this there was a study out of Boston. It wasn't Boston Children's, but it was out of Boston by Callaway and colleagues in 2019. And they showed that of the patients that were referred for a release, 62.6% did not have to go through with the release because they saw the feeding team first. And that's huge. That's like literally, 62% of the patients that were referred that if they had gone somewhere else would have just been released. Didn't actually need the release. There was something else going on.
The last thing, just to like bring it back home, is sometimes is it tongue tie or is it a zip code problem? Because as we stated, there is research that it's heavily influenced by socioeconomics and that families of higher income, private insurance, white, non-Hispanic backgrounds have access and have a much higher incidence of having a tongue tie release when you look at the data and you pull zip codes of patients post-release. That's frustrating.
Yeah. Also validating in a way, though.
Yeah.
Yeah. Okay. So going off of that, in an ideal world, if you don't have access to, or you're not sure if you have access to something like that decision-making model, which sounds incredible, what would be the chain of assessments, right? So there's a lot of talk about rule this out first, make sure you've looked at this. What what for you would be the way to truly assess function and looking at that function over form? Who would be the professionals in that? Or maybe not professionals, because obviously it can vary, but kind of like just this is important, rule this out.
I would say I feel like I can answer that maybe from the as a provider who does home health based services. I don't work with a team that I just have, quick access to. So maybe this will be helpful. But what I find typically is the first line of defense is usually your pediatrician. That's the first person you're going to go to say, hey, I'm having difficulty with this, or XYZ is going on. And from there, depending on what exactly the concern is, would kind of dictate who you see. But I would say typically the next person would be, if it's an infant, it would be that infant feeding specialist. So that might be an IBCLC who is also an MD or a midwife, same thing in this area, or an SLP who also have that lactation training. If it's an older child, typically I actually would say an SLP being the first line of defense, because once we get past that breastfeeding, we really are the experts on the oral and pharyngeal phases of feeding. And then also speech, because sometimes that is a concern, which we can talk more about the research on that later. But I would say the SLP. And then from there, I would typically put an ENT onto the team pretty quickly if we're thinking about it from an oral facial structure standpoint. And again, some variability of what might be going on. I hate to be like, this is exactly what I would do, because sometimes it might be that, they came to me and I say, I don't think this is a tongue tie. I actually think your child is torticollis and we need a PT on the team. Or I actually think, and there may be something that hits before. But if it got to the point where we tried different strategies, we used less invasive interventions to try to support latch and positioning, and we made sure to look at both sides of the dyad and what is going on. And then I say, I still think that might be beneficial. And ENT is typically who I'm going to make that referral to, a pediatric ENT specifically.
Is that because airway for you is the next most important thing to consider?
Yes.
And we're gonna get into risks later, and risks of intervening or not intervening, and what true informed consent is, but just from an overarching, that it's the airway.
Yes, I always would like to get an ENT's eyes on a child, an infant, before a release happens, because of the potential risk of, and the American Academy of Otolaryngology had neck cancer. They really came out and said if you release a tongue tie without considering airway, you could cause or exacerbate sleep disordered breathing, obstructive sleep apnea. And so for me, that clinical guideline really says, let's just make sure that somebody is looking at the airway in a way that I can't before they decide which direction to go for a release.
And Casey, one thing I would add to that is that we have the referrals always tongue tie, always. It's a tongue tie, but walks in it as a tongue tie, does not walk out as a tongue tie. And we have had, I would say, 4 to 5 infants that have come in question of a tongue tie where we've actually diagnosed a cleft palate. So they have a hole in the soft palate in the back that's hard to see. And Yvonne would probably talk to us about it's hard to get in an infant's mouth and look in the back. But when you really get in there, if you have a hole, a cleft palate, then you can't get suction and you're going to be a poor feeder. So just and that's rare. Yes, that's rare, but out of an abundance of caution, what else is going on?
Yeah.
That's interesting, Cara, because over the years, I've always examined the back of the throat and the entire mouth. And only once did I actually find a cleft. But when I was speaking in Birmingham in England last year, they actually had a gathering of the people who perform tongue ties in the community. They're especially trained. They're trained through a university, and it's a high standard of service that these people are providing. They're not surgeons, primarily midwives, lactation consultants, or registered nurse and lactation consultants, and they're trained to do simple sternotomies. But they had a woman representing the Cleft Association come and speak and tell these people, you've got this baby in front of you. You need to do a thorough examination. And despite the ultrasound screening that most babies will get before they're born, there are many clefts that are presenting late, into the 2nd or 3rd week of life. Wow. So that is a very important thing. And I think when I look back on our statement from ABM, we talk about confounders. My problem, I think pediatricians in general are, of course, trained to detect disease and anatomical variations of children, but to recommend a pediatrician who knows not very much about breastfeeding is quite. So in the people that I would suggest that they see is definitely people who are identifying themselves as being expert in breastfeeding and lactation medicine. And now we actually have a board certification process for at least US and Canada physicians who are involved in this space. So if you see somebody and they have the NABLM credential on their wall, like actually I do, then that's telling you that this person is very seriously and committed to that whole area of keeping up to date and understanding the situation to be able to be best placed to give you that advice. Again, as I said, the decision always rests with the family, though.
Yeah. Wow. We're going to get more into this in a bit, but I think one of the big things that often comes up from a parent perspective is that question of, why does this seem like what everyone is talking about right now? Why does this seem almost like a fad right now? And I think part of the danger with those like fad type things on social media is that it takes away from the legitimacy, but it also plants those seeds of doubt. I would love to hear your opinions on the research, if any, that speaks to kind of that rise in diagnosing and intervening. Is it a rise in diagnosing? Is it really a change in our jaws societally because of what we're eating? Can you kind of tie that together for us, for anyone that's like, it's the new hot button thing?
I think, part of what we talked about earlier about, certain zip codes, for example, definitely playing a role in terms of some of that we're seeing, because they are being targeted to move forward with that. But what we are seeing an exponential increase. So there's a couple studies that looked at it, and they've shown a 7-fold increase in diagnosis and 10-fold increase in treatment in the United States and Canada, and a 4-fold increase in Australia since 2000. And that was as of 2020. And so some of the reasons that people are guessing this is inconsistent definitions. For every person who says X is a tongue tie, another person's going to say, no, that does not mean it's a tongue tie. And part of that is because the tools that people are using to measure it are typically related to form. So the anatomy, what does it look like? And they have not been tested or have very poor psychometric properties, which means, like, for parents that are listening, that means that we're looking at like the reliability and validity. Does this test look at and say, okay, based on this information, it means that this is the outcome, for example. And what we're seeing is that it's very, very poor. So just because you have a certain score that can look like, wow, this is a really severe tongue tie on these tools, and providers are using them, right? It does not necessarily mean that it directly correlates with this functional outcome. And so that makes it really hard to diagnose, because it then becomes a little bit more subjective, because we're thinking of it not just from the lens of what it looks like. It has to be based on function. And function is hard. Function is really hard to assess. And that's where coming up with having access to more standardized things can help. But that's one reason there may be a rise in the diagnosis and treatment. So poor psychometric properties related to these tools. And then also social media sharing on the topic. Social media is full of misinformation. And so we see a lot of providers, but then not just that, we see families sharing their experiences. We see echo chambers of these Facebook groups where if you share a differing opinion, you're just going to get kicked out. We see networks of providers who all just agree on the same thing. And so they're just all like parroting what the other person said without fact checking any of it. And so social media is definitely considered one of those reasons. And one thing I do want to bring up, because I feel like sometimes what I hear from people is that they say, well, there's an increase in frenectomy rates because there's been a push to breastfeed more. And so we're seeing an increase in breastfeeding rates. So that's why we're seeing more frenectomy rates. However, in countries with the highest breastfeeding rates, like Japan and Malaysia, frenectomy rates have not increased. So that tells us that does not explain the increase in frenectomy rates. That's kind of my take on it.
I love it.
I think the breastfeeding part of that, Bree, I would say that one of our downfalls, and I'll include your country as well, is the lack of support, the lack of availability of support. So it's not good enough to say, okay, everybody breastfeed and just do it because it's normal and it's natural and it's whatever. And so we know that there are a lot of people that experience obstacles because they've lost the intergenerational support that people would have had in how to feed your babies. So, I look at it from the parent's perspective. They know that breastfeeding has benefits beyond any other alternative for the baby. For the mother now is a very big area as well. So they in themselves, and rightly so, want to breastfeed. But if you are in that situation and good, effective, supportive help is not available and somebody's dangling a carrot in front of you of a quick solve all your problems, procedure, what have you, it's going to be very tempting because as a Western society, we're very geared towards instant solutions, pills and instant treatments, and very ungeared towards slow, gradual rehabilitative processes. So I say from the parent's point of view, it's really hard for them to say, I'll take the longer course, then maybe this thing is all I need and then all my problems will be resolved.
I love that perspective. And just to speak to that really quickly, even for me, it felt really scary to say, I'm going to wait, because it's you have, again, these people who are essentially in a position of authority over you talking about weight gain, how, throwing around terms like failure to thrive, or, there's all of these things that it feels really scary sometimes to take that long road, especially because so often, if you're choosing not to move forward with their intervention, they're like, okay, best of luck. Like, where do you go next? What do you do next if you're choosing not to intervene? And when you're holding this brand new human that you're responsible for, it feels so scary to wait. But I feel like what you just said is so important for parents to hear, that it's okay to take a step back and give it a little bit of time in a lot of situations.
I think, we are always of the mindset of time is on your side. And if you're sending us a 3-day-old, has mom's milk even come in? What type of support system does she have? How is she adjusting? Has she breastfed before? Is there a toddler in the house? Do they have family close by? Is mom taking care of herself? Is she hydrating well? Does she have a support system? So I feel like we act so fast. It's a tongue tie, it's a tongue tie, it's a tongue tie. But let's step back and see, are we taking care of our moms? Are we empowering them, right? You're going to be much more successful breastfeeding if you have support and people around you that are helping you. But if your milk hasn't even come in, of course the baby's not going to have a great latch. And of course they're going to, initially fall asleep at the breast.
I also think, though, that this goes back to true informed consent and going to someone who can really say, it's okay if you want to wait. It's okay if we want to try these other things first. And here are the risks associated with it. Instead of, truly, it was presented to me as proactively, it's there. Let's do it. Just be done with it. And looking back in hindsight, I'm I was so vulnerable. I was in such a vulnerable state. I couldn't even rationalize in my own head, even with a background in medical in general. I couldn't work through it as a mom. And so it just breaks my heart that so many parents are making quick decisions because they feel scared and they want to just do the right thing by their baby, but they're not being given all of the information to be able to truly make an informed decision. Hey friends, Casey here. If you've ever listened to an episode and thought, I wish she'd go even deeper, or I wonder what she really thinks about that, I am so excited to share More Than Milestones Unfiltered, where I do exactly that. More Than Milestones Unfiltered is my private Substack community where I share 2 exclusive podcast episodes every single month. 2 episodes that will never make it to Instagram or the public feed. These are the even more raw, unfiltered stories, harder conversations, and the that's a story for another day moments I usually hold back on. If you want to join me there, just head to the show notes or my link in bio and subscribe. I'd love to see you inside. So since we're talking really function over form and that sort of thing, can you walk us through what are the big indicators that a parent should maybe keep an eye on something, or maybe should pursue an oral valve, or maybe should really consider looking a bit deeper? Are there big things? Obviously, breastfeeding is a huge one, weight gain, that sort of thing. But what are the big things that you would say if a parent was kind of unsure of whether they needed to have an assessment done would be go? this is important?
I think maternal discomfort, for the breastfeeding mom, like, is she having pain? Is she uncomfortable? I'm often like not more focused on the mom, but, can we make a position change to improve her comfort? But if she really is uncomfortable and has trauma to the nipple and the breast area, is that because it's a shallow latch? So it's like, let's look at the baby. Let's look at their oral cavity. Let's look at their tongue. Let's look at range of motion. But then let's look at mom's breasts and see, why is she so uncomfortable? Is it because of a restriction? Or, do we need to help her, like I said, with positioning or things like that? So that would be one thing I think we need to think about is mom's comfort level.
Yeah, and that's a bit of a drawback with some of the tools that we have that Bree alluded to, is that they focus on the baby, the infant only. And I think, those of us who work with breastfeeding dyads, there's no such thing as a mother and a baby. There's a mother and a baby, and they're an intricate unit. And so the other thing that I would lead me to thinking about it is if the baby is either having faltering weight gain, or they just seem to be inefficient at transferring the milk, in that the mother can express a lot more milk than the baby's able to take. And the baby, so there's good evidence if you go back in the early 2000s about what is actually happening in the mouth of the baby when they're breastfeeding, and the positioning of the nipple and the ideal positioning of the nipple. And so we know that if there's limitation in the range of motion of the tongue, it's not going to be easy, not impossible, but it's not going to be easy for an infant to position the nipple in the ideal sweet spot, if I call it, on the just close to the hard and soft palate junction. So the roof of the mouth, and I don't have to tell SLTs about the roof of the mouth, but it's there's an actual spot that the tongue has to lift and position the nipples. So transfer of milk in addition, and yes, very much so, maternal discomfort, very much so. So again, seeing a breastfeeding session should give you some clues rather than just taking a report from somebody that's somewhere else that sends you that report. Very intricate part of the assessment.
Yeah.
Bree, I'm gonna hit you with this one because I think I already know. For older kids,
Yes.
I would love to hear your thoughts on claims. And I don't mean to be already presenting this with a tone. I'm sorry. I have a little bias that I'm obviously working through. So minus my tone right now, can you share any supporting information or disputing information related to a lot of the claims for older children or beyond the breastfeeding stage? Things like mouth breathing, things like attention issues, sleep concerns.
So I think first, I have two things I want to broadly say. So one, I want to be very clear to just everybody listening that Cara, Yvonne, and I are not anti-tie people. We are anti not receiving informed consent. We are anti you not having all of the information available. All of us have referred infants for release. We have made those referrals when it is warranted. And so I want to be really clear about that. Secondly, we briefly mentioned earlier, and I think this is related to the topic of older kids, about doing something proactively. If you are ever with a provider who is like, hey, I know you say with some positioning and latch changes, things are getting better, but because we've identified a tongue tie, you should go ahead and do it to prevent XYZ. That is a red flag. There's zero research to support that we should be releasing a tongue tie preventatively to not lead to something else. Same thing with the labial frenulum. I know sometimes people say we'll release it because you don't want to risk there being a gap between the teeth. And what we see with normal development is that labial frenulum naturally just moves upward as the child grows. And releasing it does not necessarily mean they won't have a gap between their teeth still. And we have to consider scar tissue that could build up there instead. And so preventatively, that's also kind of a red flag, because it leads into some of the things that, I see on social media a lot. And I know that we all hear about what to do with an older kid. So I'm going to kind of talk on some of the things you mentioned. So I know mouth breathing is one thing that comes up very frequently. And we do not have causal research that shows that a tongue tie causes mouth breathing. Now, there is some research that uses some of those tools that we mentioned that do not have good psychometric properties to say, oh, well, a score on this was attributed to mouth breathing. Again, that score means nothing. It's not reliable or valid to say that it caused those things. So it's like correlation versus causation, right? It's like, oh, a score on this was correlated with mouth breathing. It does not mean that it was causal. It does not mean it was related to that, because we don't have good validity in those tests to tell us that that is the outcome. So you will see people that claim research and cite research, but it's pretty poor research in terms of the methodology. So we don't have that direct correlation there. The other thing I want to mention before I get into the older side of mouth breathing is that infants are obligatory nasal breathers, right? So we want infants to breathe through their nose. They have to. How else are they going to feed on a breast or bottle if they can't breathe through their nose? However, when an infant is at rest, it is very normal for them to have approximated labial closure, so a small gap between their lips, until typically about like 5 or 6 months, when it starts to get a little bit stronger and they advance with solids a little bit more. And that's kind of when drooling starts to decrease a little bit. Drooling's still normal, especially when your child's teething, like those things are going to happen. But I bring that up because as long as their tongue is still suctioned up so they can breathe through their nose, that's okay. Now, going into like, would we want a referral if we notice that our infant is breathing very heavily through their mouth, having trouble feeding because of that? Yes, I would want to see a provider to figure out like what exactly is going on. And sometimes it is like congestion or allergies or something like that, where it's like, hey, nasal suction before you feed might be enough to help right now. But kind of bringing it up from the mouth breathing side. In terms of older kids, same thing. If I'm concerned about mouth breathing, I am making that referral to an ENT. Majority of the time, mouth breathing is due to allergic rhinitis, so allergies causing congestion, enlarged tonsils, enlarged adenoids, or sometimes something like a deviated septum. Those are kind of like the most common. There, of course, can be other reasons for it, but those would be majority. That's, again, why I would want to go to that ENT provider to rule out all of those things. Moving into, the other thing that comes up oftentimes with older kids is speech concerns. We do not have good data to show that a tongue tie leads to speech concerns. If your child, for example, a lot of times people say like, well, my kid can't make the L sound, the la la la, the L sound, but they can make a N, they can make a T and a D. That's all the same position. If they can do those, they have the ability to create the L sound. But a lot of people are like, well, this one's harder. They have to hold her. There's all these different things that say. No, if they can reach that placement, they have the placement available. It's just a modification of how they're producing it. And so a lot of those things come up when we're looking at sounds. And so from a speech standpoint, we just don't want to jump to it. And I always like to say, like, I never say never. There may be a possibility that, a child's having trouble there, but really it's highly, highly, highly unlikely. Also, there's a lot of different ways to produce a sound. You don't necessarily have to have your tongue tip to come up for it. There's a lot of ways to create sounds that aren't, the quote unquote textbook version that are still completely functional and appropriate. So that's something else to think about from the speech standpoint. And then if someone is concerned about speech sounds, though, the first thing I want to say is I find a lot of social media posts and talk about speech when people actually mean language. And there's a difference between speech and language. And so someone will say, oh, the child doesn't have any words yet. It's probably because they have a tongue tie. No, if they don't have any words, they are not vocalizing at all. I am more concerned about their language. Are they understanding? Are they even attempting to make sounds? Speech is how we articulate the sounds. And so I want to be clear there, because a lot of times it'll, oh, my child only says one word utterances. They're not making 2-word utterances. Could it be because of a tongue tie? That doesn't make sense. That's language. That is a language base. If we are worried about a tongue tie, it would be specific to the articulation side. And there's many sounds from a speech side that we do not expect a child to have until they're 4, 5, 6, 7 down the road. So that's another thing. And if somebody is concerned about speech, you want to make sure that you're going to a speech language pathologist, speech language therapist, and getting a formal standardized speech evaluation. So they are running through a standardized test to actually say whether this is age appropriate or not. Because sometimes it is age appropriate. It's an error with the sound that's just part of typical development, and that's okay. And then third thing I would say about speech is if you feel like your child is not making progress, never, ever hesitate to get a second opinion, to ask another provider, to see another speech therapist, because sometimes, I'll be honest, I wonder what the therapy that's being provided is, because there is a thing such as bad therapy, and if this is a child who I find out has been doing bubble blowing and button pulls and wagging their tongue back and forth and very, very little practice on actually articulating the sounds, that might be why progress isn't happening. And they may not be choosing an intervention that is specific to the speech sound disorder that the child has. And I'm going to give a shout out to Amy Graham on Instagram, because that is a really good speech sound disorder account to follow.
I love that. I love that. And so one other thing that I think comes up a lot when it comes to function is even things related to like overall posture, the way they're moving overall, right? So there's so much information that we have about fascia and how everything is intertwined, and how if you're seeing X, it could really be related to Y. And it can be really hard to kind of tease out what is true and what is not. Is there other parts of of a functional assessment related to tethered oral tissue, deciding whether or not to intervene, that any of you would ideally want to see, related to kind of their overall presentation, their overall function, not even just orally?
Well, I think I definitely see a lot of people that come to me wanting an assessment for a potential tongue tie, because I do the treatment. But I see interventional births with a lot of musculoskeletal dysfunction happening, and it's outside of the oral cavity. So I think things like torticollis, or, the baby having a side preference, positional side preference for their head, just general hypertonicity, a baby who's very tight and, posturing at the breast in a way that is unusual and not relaxed. So that's why I mean the confounders are really important when somebody comes, even if they say the baby's not gaining and I'm having pain, that still doesn't equal, yes, your baby needs a surgical procedure on their frenulum. So yeah, I see interventional births, I would say, what I mean by that is potentially ventouse deliveries or forceps deliveries, prolonged labors, precipitous deliveries, and not necessarily, I'm not meaning cesarean section, but I'm meaning the things that are happening to assist the mother in having the baby out.
Yeah. I would totally agree with that, Yvonne. And I think that's where like truly our assessments include looking at all of those things, like looking at feeding, considering speech, considering breathing and airway, considering posture and movement and compensatory movement, looking at all of those, but realizing like the tongue tie didn't cause all of those things, but all of those things could be playing a role in what we are seeing functionally, and then making an appropriate referral to who would be of help. So when we're seeing, like if I'm seeing some of those posturing or movement patterns or tightness in the infant, saying, okay, I really need a PT to be part of this team. I always say that I think it's very, very rare that you could diagnose a tongue tie within the first session of seeing a child, because it's really important to consider all of those other factors first, and then it can kind of happen. And when I say diagnose a tongue tie, I do not diagnose a tongue tie, but it's very rare that the first thing I'm going to say to a family is, I think there might be a tongue tie going on, because I am looking at that child from such a holistic lens.
I do think that early feeding difficulty can be the first red flag that there may be something else going on with the child, not a tongue tie. And just as Yvonne said, the hyper, like tightness, the rigidity, or babies that have low muscle tone, and a baby does have maybe an open mouth posture, or at rest, the tongue is in a forward position because of the low tone. Again, it's not because of the tongue tie, but then we have overall tone issues. So then I'm going to call the pediatrician and say, I'm worried. I think there could be something else more global going on here that might need, more in-depth look at it. So
I think, Cara, what you just said, it made me think of, like, again, the importance of a tongue tie is possible, but is it the most plausible thing that's going on right now? And you thinking about the low tone, for example, I had an infant who came for a tongue tie referral, and they ended up having spinal muscular atrophy. But they were like, oh, the tongue is not functioning as it's supposed to. Is that what's going on? It's like, did you look at the whole child though? Did you, find out that they've lost skills? And I've had so many like that, or laryngomalacia, or laryngeal cleft, or things like EOE, just like so far out there that was not at all. But I always say, like, tongue tie goggles, if that's all you see, if that's all you're looking for, you're going to find it. You will find it, because we all have a frenulum. So anyway.
So going off of that, so we've talked about what to understand when looking at function and advocating in that way. But I think it would maybe be helpful for parents navigating this to literally break down what's the biggest benefit that you typically see post-op. Obviously, we would want to see an improvement in function, right? But I'm sure there's others. And really then the risks as well. So what are the risks associated? Kind of just like painting the full picture of informed consent. So what can parents hopefully expect post-op? And then what should they be considering as potential risks going into it or making that decision?
Well, I think the first risk is that you go through a very stressful procedure and you get no improvement. And I tell people that's that there's no guarantees. The only thing I could say is that I feel by releasing the frenulum, when I get to that point, I am definitely going to improve the range of motion of the tongue, but I cannot with certainty say this is the missing piece for your breastfeeding issues. So, and I think the possibility, especially I've seen this over my years of doing these things, if a woman has a hyperlactation or an overproduction of milk and you release that tongue, there's a critical time to do it, because if you release it at the wrong time and a baby is suddenly triggering even more milk flow, it can be a very delicate situation that they could actually end up experiencing aversion to the breast by the baby, because of course airway is number one. And if you're being overwhelmed with flow that you didn't have when your tongue wasn't really doing much, then that's a potential there as well for those are like the immediate things I would say. And of course there is a risk of bleeding. And over the years, I've trained lots of people, doctors primarily, that have come through my clinic in the procedure. And I have never had any medical emergency related to bleeding, but they have had, which is interesting because one of our worst cases in this part of the world was a person who did their very first frenotomy. It was a medical professional, dental professional actually, with scissors. And the infant had a cardiac arrest related to blood loss. So we are talking about rare events, but we're talking about potentially very, very serious potential for bleeding. So, and I don't know enough about that case to know, obviously there was a vessel that was severed, but why it happened in that particular situation, I'm not sure. But I have had, like I said, a few of the people that I've trained have actually experienced significant bleeding that needed to go into the operating room and be addressed. So it is possible, but yeah.
And Casey, this is what we were kind of prepping and talking about is now the vitamin K shot that is typically given in the newborn nursery when the baby is born. And we have seen an uptick in parents refusing vitamin K. This isn't a vaccine, it's a shot. Vitamin K is essential fat-soluble vitamin for blood coagulation and tissue calcification. And when parents have begun refusing the shot, like Yvonne said, there can be an increased risk of bleeding. So to put safety nets in place at the institution I'm at, if parents don't consent to the vitamin K shot, then the child is not a candidate for a scissors release of the tongue tie. I can start this. I'm sure Bree will take this from me after as well. But are these stretching exercises? So you're like, what is the risk postoperatively? Or what are the benefits? Well, hopefully the benefit is that mom has more comfort with the latch, with nursing, baby's transferring milk, weight is in an upward trajectory. But there are a lot of concerns about the instructions for these stretching exercises for some of the infants that are having the laser release and families that are like waking the baby up, to do these stretches overnight. The baby's crying, mom's crying because they don't want to do it. The baby then can develop aversion because of that negative association in and around the mouth. So there's significant concern after the laser release of the ties, sometimes about how sort of invasive these stretching exercises are and what little evidence there is to support the frequency with which to carry them out.
Yeah, I think I will definitely add more there in just a moment, but I did want to reiterate that, most of the benefits that we are talking about are on social media. You see them exacerbated. It's a very quick fix. It's going to be a miracle cure of everything. And what I think we've all said and what I'm going to reiterate is that it may help some things. It may not. And it may help something a little, but there is still a road of therapy and, the tongue figuring it out after there. And there's things that we needed to do beforehand. And so it's not just a go to the procedure and you're done. There's quite a lot that goes into the before and after. to make sure that it is successful. Wound care wise, I do want to bring that up because I think that it's an area where we talk about risk of the procedure, but there's also risk involved in some of those recommendations that are made for massaging or stretching the wound thereafter. And I want to be clear that it is not my scope of practice to give the recommendation to do active wound care. Okay. I do not give that recommendation. I can regurgitate some of the research here for you, and I'm going to regurgitate some of the things that the pediatric ENTs that I work with, how they approach things. But I do want to be clear. And if anyone is doing wound care outside of their scope, again, major red flag. Like if you go to see an SLP and they're providing you with the active wound care protocol if you're going to do after a release, like, whoa, the physician, the medical provider doing the release, they are in charge of what your wound care is going to be. Now, does that mean I won't sometimes question it or call the provider or ask, like, is some of these things necessary or not? Sure, absolutely. But that's that interdisciplinary care, right? That's me saying, hey, I want to make sure that I understand this. Here's what I'm seeing on my end. Are we sure that this is, what's best? So I'm going to kind of talk from more of the research standpoint. So what we see with the evidence on wound care is that there's really a lack of support in doing anything. And there was actually a study, I don't want to misquote it, it was like Bondarkar and colleagues in 2022. They did a retrospective study of 599 infants, and they showed no difference in breastfeeding improvement or recurrence for those who did post-frenectomy wound care versus those who did not. And this gets me so heated inside because I see so many parents blamed for not doing enough. And that's why the reattachment happened. Well, you must not have stretched it hard enough. You must not have done it enough. You must not have done it frequently enough. And these parents, as a caregiver, like, that is so hard to do.
It's crushing.
Yes,
it's crushing.
it makes me want to cry just thinking about it because like your child's in pain when you're doing it, right? Like they are screaming, they are crying. There is a risk of an aversion because of that, because they think anytime something comes to their mouth, it's going to hurt. We risk things like attachment, especially really, really early postpartum when a mom is so fragile to what is going on and so vulnerable. There's just so many things that we're risking. And to me, what the research says, what we're seeing on these outcomes, it's not really a risk to benefit situation because the risk of harm is significantly higher than the potential benefits from doing it. And typically, if you go to an ENT, you go to someone who is doing the scalpel procedure instead of the laser, they don't recommend it. What's really helpful is to then breastfeed, to keep breastfeeding, to breastfeed frequently, because then you're practicing the tongue movement that you need with enough range of motion to still support healing of where the tongue should be. And there's no standardized protocol too. You'll see providers recommend so many different ways of doing it. Sweeping. No, go on either side and pull back and hold 3 seconds. No, actually go do this, or do it 3 times a day. Do it 6 times a day. Don't wake your baby. Wake your baby. Like, so many different. I've also seen providers sell like bite blocks to hold the mouth open so you don't get bit while it's going on. And I used to work at a place like that, and it makes me so sick to think about. And then there's not even to mention the potential risks of like infection that can occur because we're putting fingers in there. Hemorrhaging, again, bleeding concerns, and just so much more that comes by it. And I think too, as professionals, we need to think about the ethics behind training a family to do something such as wound care and their expertise in being able to do that in a manner that's appropriate and effective. And we're not seeing in the research that is making much of a difference. So I think it's important to think about. And then on top of that, like worldwide, the Australian Dental Association, Academy of Breastfeeding Medicine, and the American Academy of Otolaryngology Head and Neck Cancer all say there's not enough evidence to support doing this. So we have multiple medical organizations and scientific statements confirming like, hey, talking to parents, push back on that a little bit and really, really determine if it's necessary.
I just want to add this part because I'm like fighting back tears right now, remembering the newborn days with Austin, who I did choose to intervene with, and I have 4 years later so many regrets. If you're a parent listening to this and you are feeling guilty or like you should have looked harder or researched more or done more to figure it out, like please do not hear anything that we are saying from the lens of like you did wrong.
Absolutely.
You weren't provided what you should have been provided.
Yep.
I'm not going to cry. I'm just going to keep it
100%. Like,
moving right now.
100% the provider's responsibility to
And Brie,
inform.
I didn't take anything that you said as what made me feel that way. That this is just an internal, like, that was super understanding.
But like, that is a natural response, right?
Yeah.
To being like, wait a minute, they didn't tell me that information.
Like, I did what you said, and then now I could have been hurting them, you know? It's
Right.
like, yeah.
And again, if someone shares with you, like Yvonne said, it is the parent's decision. So if I say, hey, research is very limited in that. I know some providers recommend it.
100%.
If you feel strongly about doing it, then you can follow, you know, what they are giving you. But I just want to let you know that the research is limited and there's not likely a difference. Like just providing that so then the parent can say, you know what, I do want to do it though, because I feel like it could help. Fine.
Yeah, that's that true informed consent. Literally hearing that and being able to make the decision myself of, do I want to put my child through this, or do I want to just let healing happen? You know, it's frustrating.
Well, that same study that Bree mentioned with the 600 or 599 procedures, you know, 43.5% of the parents did not do the stretches who were instructed to do them. And the reason they didn't, because it was anxiety provoking. There was reluctance to touch an operative site, which sounds pretty reasonable to me. Fears of harming their infant, bleeding, pain, and awareness of conflicting advice. The people that don't do them, and I agree with what Bree said, there are providers that will flip the responsibility for a poor outcome back on the parent who didn't do enough or as directed or whatever to do with the post-operative stretching or maneuvers, whatever you want to call it. And it's important to realize that if you were one of those people and you happen to be listening, you have good company, because intuitively we don't want to inflict discomfort on our babies. And that's I support that 100%. So please don't feel bad. And I also have a little comment about the word guilt, because I think mothers and women in particular, all sorts of ways in healthcare, because I do general or family medicine as well, guilt is such a waste of time. Guilt should be rechanneled into a militant sort of determination to the people of the future not experience what you experienced.
Yeah.
And I think guilt is probably more likely grief and regret maybe, but guilt really is self-destructive. So let's try to move away from that word as much as we can.
Yvonne, that is so empowering, and I wish you told me that 30 years ago.
No, but it's really chewing on the inside of my cheek.
That's really powerful.
It really is. And I know I'm not the only person that needs to hear that is going to be listening to this. So thank you for that. I want to circle back really quickly, because another regret, not guilt, I don't feel guilt about this, I have regrets, is that with Austin, it was, again, like I said, it was day 2 of life. They came in, they said he has it. Nursing was really painful. I was like, okay, do what you got to do. He came back. I wish that I had pushed harder for before care and for aftercare. And you touched on this a bit ago, Brie. Why is it so important for parents from a tongue function standpoint to really care about not just going in and taking care of it if that's the recommendation, really kind of like supporting the recovery process before it even happens if you are choosing to intervene?
Yeah. I would say there's a couple different reasons that's so important. One of the first ones would be that we find out that something way less invasive was beneficial. And that is all that was needed to change. That is the route we actually needed to go through. And like, if we are making progress, they're great. And that's something too that sometimes I see where people say, like, you're going to go through therapy, and if you're making progress, like, we're just timing it for the release. And like, no matter what progress is made, they're still going to push for the release. And to me, that's a little bit of a red flag, because what we are doing beforehand is really saying we are going to use the most evidence-based interventions we can to try to improve what's going on, to get the people on the team that we think that are needed to work holistically and say, we've checked all the boxes, we've done all the things. And if we get to the point where we say, okay, progress seems to be stalling, or we're plateauing, or maybe there are some things happening where we're like, wow, everything is going really great, except transfer of milk is just not happening. And like, everything's checking the boxes from mom's side. You know, we're not seeing anything major on the infant side. Then we would say, okay, let's go forward with release. So I think it's kind of twofold. One, you're like getting them as far along as you possibly can with a least invasive intervention first, something that typically has a higher evidence base as well. Or you're just making sure that like you've checked off all the other things that could have been going on to say, okay, again, research is limited. It may not help at all. It may only short-term relieve nipple pain. It may, improve, XYZ for a little bit. But for me, kind of go back to where you're talking about the benefits. Sometimes if the benefit is truly just short-term alleviation, but it is enough that mom's nipples are healed, the infant is transferring milk in a way that they can improve function over time. Like now we're getting repeated, really good breastfeeding sessions in. Even if it was short-term, I'm glad because now it's helping long-term outcomes. And so I think the main thing with the pre is doing to that. The other thing is the pre is making sure that this is a child who's even ready for it. If an infant is not latching on the breast at all, completely refusing to feed at all at the breast, they are not going to necessarily be ready for a release. Because after that release, I need them to be feeding from the back. I need to at least get them to a point where they will latch on for a little bit, even if it's a short amount of time. Because ideally, we have the release, and then what we know from motor learning and neuroplasticities, we want to practice then the skill that we're trying to improve. So if this is a child who isn't at all, that also tells me they're not ready for the release, even if I think that might be what's going on. I first need to figure out why they won't come to the breast at all, and kind of work back from there. So I think that's another thing, because sometimes I'll see that like, oh, they won't go to the breast at all, do the release. It's like, well, I don't know that's necessarily going to increase their odds of like wanting to go to the breast at all. So it's kind of it's complex, it's tricky, but it's really important to make sure we're ruling out or preparing them as best we can for when the release happens.
There's so much that can confound the situation, and it's not actually fair to present a procedure as the end-all be-all quick fix when we know that all these other confounders exist. But I think, in my view, it's that assessment, even when you get to the point of you're sitting with the person who could potentially do the procedure, they have to have a process to do that final assessment. And there's no tools in existence that are going to help them. And I just wanted to mention this because I'm actually, one of the other things I'm involved with right now is an international group of people who have been involved in the management of tongue tie and breastfeeding medicine for combined, I think we're 95 years of clinical experience and around the world. And we're trying to develop a clinical process guideline for the person that's going to do the procedures. All along the steps that lead that baby to treatment, there needs to be assessment and reconsideration and informed decision making.
Amazing. I love that. That sounds absolutely incredible. I think we've overall covered pretty much everything we were hoping to. Is there anything else you feel like is really important for a parent navigating whether to intervene, whether to not, whether to try non-surgical interventions first? Is there any other piece that you're like, actually, this is really important? Let me mention it quick.
Maybe there are adverse outcomes, like a person who's performing the procedure. If it was a surgeon in a hospital, they have a certain amount of accountability for the procedures that they've done. And they'll say, okay, I've done appendectomies for 30 years and I've never had blah, blah, blah occur. So I think that's a little bit of a missing piece, that people need to be accountable for what they've done in the past and what their rate of success, if you want to call it, or just some form of feedback from the actual provider, I think is important with that informed consent.
Truly, majority of the time, there is something less invasive or higher evidence-based that we can do to support what is going on. And while a tongue tie is possible, it's just not usually the most plausible reason for what's going on. And so, no matter how much social media or like the cash pay provider tries to quickly get you in to do all the releases all at once, they try to tell you, it's really important that as a parent that we slow down. I mean, we make sure that we feel that we have received informed consent in what's going on.
The one thing I would say is sucking blisters are normal. That's the other thing. Oh, the baby has sucking blisters. They have a tongue tie. It's normal to have sucking blisters are normal.
About chapped lips in older kids.
If they're licked all day, normal. I just think we pathologize everything.
I hope all babies have a double chin. Like
Right.
The double chin means that their tongue's hanging too low, or that if they sleep with, this was the big one. If they sleep on their belly with their booty in the air, it's like an airway issue. No, they're just going in the fetal position. They're just cozy and comfy.
I don't know if I ever told you this, but I don't even think we were like friends at this point. You stopped a spiral for me that I actually don't think I was convinced that Austin had micronathia. Is that what it's called on the bottom?
Yeah.
And you just happened to post something that you were like, normal. And I was like, oh my God, we don't need jaw surgery. I went down that rabbit hole so fast, and you were my little light at the end of the rabbit hole. So
that's so funny.
to speak to the over pathologizing, especially with social media, like we have access to more information than ever, but it also can be really hard to sift through that as a parent. And then you throw in the emotional piece, and you throw in all the fact that you are a new person when you give birth and you're getting to know this new human and you, like, there's so many components of this. So I hope that this wasn't overwhelming, and I hope that this was helpful in just understanding that if you've made the decisions and you have true informed consent and you feel really good about your decision, I love that for you. I think everyone loves that for you. But it's also okay to push back and fight for that and not feel guilt ever about that. Can you guys just give us, where can people find your work, your resources, your information? Anyone that wants to dig further, where can they look?
Anyone that comes to New Zealand, I'm very happy to see them. For my point of view, you're looking for people who are expert in breastfeeding medicine. So that NABLM qualification, or just someone who identifies themselves as a member of the Academy of Breastfeeding Medicine and says, I do breastfeeding medicine. You're more likely to get a complete assessment done than, I'm sorry, a pediatrician who has no involvement with breastfeeding whatsoever. And there, unfortunately, are those people. But yeah, look at the credentials of the person that's actually offering or available for help.
Okay, this is a side note. This is not at all what you asked, Casey, but I have to say this because of what Yvonne said. The other thing I want to say is that just because somebody said, like, I would rather you look for a provider who is trained in the area of concern you have than the specific diagnosis of like tongue tie. So you'll see a lot of terminology like a TOTS specialist, a tongue tie savvy, or things like that. And that, or like a business that is named specifically off of like tongue ties, like they have extreme bias and a lot of incentives behind convincing you that it is a tongue tie. And so if you're seeking support for feeding, I want you to find somebody who's an expert in feeding, or I want you to find the expert in speech or breastfeeding medicine, like specific to the area of concern, not the specific diagnosis, because otherwise they're starting out from that lens. And I want to say why part of this is because I have sought out training in tongue tie. I have done some of the like certifications for tethered oral tissues. And as soon as I was a person that was not like tongue tie is everything, they kicked me off of their provider directory. So I'm trained in the same things as them, but I'm not listed on the directory because I don't agree with the exact protocol or with the exact approach they take to it. So that's like kind of the credential side of like, it's one thing to like be an SLP, but it's another to like specialize in a specific population and just being really careful about it. Like you think, oh, I want to go to the person that's like trained in tongue ties. But if that is all they're looking at, that's probably what they're going to find. So being careful about that.
That is incredibly helpful.
To your actual question, people can find me on Instagram. I'm at Pediatric Feeding SLP. I also podcast that I kind of ebb and flow with making episodes on. So like, I'm not as good as you, but it's called The Feeding Pod. I also like my website, pediatricfeedingslp.com. But yeah, any of those places, you can find a way to contact me or reach out or follow along.
Amazing.
I can be found, if you look on the Boston Children's Hospital website, Cara Larson, in the Feeding and Swallowing program. If you're interested, also the Aerodigestive Society, I'm president-elect of that. Aerodigestivesociety.org is another great resource.
Amazing. Thank you guys so much for taking the time and being here and coordinating time zones and all of the things. I truly feel like this is like a healing episode for me, but also a very, very important episode in today's day and age. So thank you for taking the time to be here. And we will see you guys next time on another episode of More Than Milestones.